Casey, that's a good topic. Who do you like for the World Cup? In all seriousness, no. I mean, pick a team. Pick a team. You still going to go with England?
England, yeah.
Dr. Boggs, do you have a team for the World Cup?
I do not.
Do you watch or?
I do not.
Yeah, okay. You're not a big fan of ties or?
Well, someday maybe I'll watch. I don't know.
And this is dynamite for people watching this. So we've done you're watching through Helping Back. We've got Dr. Casey Montoya with us, Dr. Michael Boggs. You guys have seen them before, but of course, because we're all mental health professionals, we're talking about soccer.
Yeah, I mean, it's the world's game, right?
That's what they keep telling us.
We should be better at it.
Oh, shit. Hey, yeah.
Would you say we should be better?
Well, yeah. If it's the world's game, why do we suck at it?
Because Tyreek Hill plays football, not midfielder. He's like the fastest muscled human I've ever seen in my life, and he'd rather use his hands, and did that for 30 years instead of his feet.
There's all those TikToks of people building an 11-point team based off of like NFL and basketball players.
Right, like headers with LeBron, like you're going to cross to that guy.
One of the greatest athletes, 6'8", like wingspan of 7 foot.
You don't want to do soccer the whole time?
No, we gotta get serious.
We're gonna get serious about this. Okay, so
serious about assessments.
Assessments, yeah. So Dr. Montoya, we'll do the soccer one more thing. We'll pass it to you, and you can kind of walk us into that because we're getting together today. Like I said, it's hard to get us three in the same room. It's nice to spend the time, but with our schedules and everything. But Dr. Montoya had an idea about talking about assessments and had a thought about that. So walk us through what you're thinking assessment wise, and let's dig in.
Yeah, so one of the things that I'm coming across, we have interns that we bring on, but then we're also bringing in new clinicians. And what I mean by that is they've recently graduated, just got their licensure. And as much as I love our education system for social work and counselors, there's not a lot that goes into it other than here's the DSM-5, read it, let's review a couple case vignettes. And it doesn't really go through the intake process or the diagnostic process and what that actually entails in session. So I just thought that would be a great educational piece for us, but then also for our client's perspective, having that voice or having that understanding, like what to expect if you're brand new to our field.
Yeah, no, absolutely. And in the psychiatric world, I mean, Dr. Boggs, it's obviously a lot of assessment based. Was your educational system or your educational experience different than Casey's, or did you feel like it was lacking?
Yeah, I'm not sure. I don't know what the training was for in the social work. There's a fair,
But in your world, did you guys spend a lot of time on the diagnosis and differential part? I mean, that's like the whole game.
A fair amount. It's things to keep in mind for people that are new. You want to try to get as good a picture as you can so that you have a sense for what you're treating, but also realize that it's sometimes for a long time, but at least for a while, it's often like a working diagnosis. So there might be a couple of different things that you're working on, and then you can kind of clarify. So there's different kind of spectrums of symptoms that can then be connected to a lot of different syndromes. But as long as you're kind of, in the ballpark, for me, from my standpoint, it was more kind of focused on, well, what can we do to help this person, and so what are they struggling with the most? So the conversational, so usually first off, any intake is just letting them talk, why are you here? What can I help you with? Then they can often lay out a fair amount of stuff. And you can get a lot of differential diagnosis can come about in an organic conversation. So if you just talk to them about why they're there, what they're struggling with, what's been their history in treatment, you can even cheat, which I do. What have you been diagnosed with in the past? Do you think, was it accurate? Was it not accurate? And then I'm often looking at targeting symptom clusters with respect to psychopharmacology. So I'm looking at, do we have anxiety? Do we have depression? Do we have bipolar disorder, or is it unipolar depression? That's a big differential between bipolar versus unipolar depression because it's treated quite differently with medications. Choices are different. Are there issues with attention and concentration? Are there issues with trauma-related symptoms, ongoing sequelae of childhood or adult trauma? Is there some degree of psychosis, paranoia? And then you can kind of drill down from there. And I think one of But what does that mean for somebody? Like if you look at the DSM, there's like 600 things that are listed, and that's probably not accurate, or maybe it is, but it's probably just different behavioral and learned manifestations of maybe a smaller number of things. And so really, where I'm usually, looking at least to start with is you're looking for depression, bipolar disorder, anxiety, PTSD, ADHD, psychosis, OCD, and right there, that's like 95% of what you might see. And then oftentimes people will have more than one thing. So it's not usually someone will have, they have PTSD, but they don't have issues with anxiety or they don't have issues with depression. Sometimes they don't. Sometimes it's one thing, but oftentimes there's multiple symptom clusters and they will meet the criteria for multiple diagnoses. Personality disorders can be useful to diagnose, especially borderline personality disorder is a common and useful diagnosis. That can help inform treatment. You can continue to revisit it, so there can be like this sense of like when you start, like, oh, I better get it perfect, or like I've like messed up somehow, and it really doesn't work quite like that. And it can be, you get to ask the question again. If you forget something, you can ask again. If you forget it today, you can ask it at your next session tomorrow. So
it's interesting, Casey, because when Dr. Boggs kind of crossed that line talking about kind of the primary disorders and then to personality disorder, it feels like in the social work and therapy world, we have more time and just sort of like client contact to really dig into that personality disorder type side, access to and beyond. Whereas unfortunately, the way the system's structured, psychiatrists may not have that depth or, that contact. So is that kind of how you present it with your new trainees or the people that you're teaching? Do you focus on one versus the other, or do you kind of ask them to be aware of both sides of that equation? Like, how do you introduce the concept of assessing, to new students or to new therapists?
I start with just giving them kind of like a chain of sorts, right? Like just kind of like, this is A to Z. This is kind of what we're looking through. Almost identical to what Dr. Boggs was saying, right? Kind of starting off with the presenting problem. What are you here for? And right, just give them that time, that freedom, just kind of voice everything that's going on, and teaching them to kind of pick out the client's own words for those direct symptoms, right? So like, I can't get to sleep. All right, sleep problems, right? Sleep disturbance, or however, whatever clinical terminology you want to use on that. I'm getting mad at my mother really quickly. Irritability, right? And so we're able to start to do some of those check boxes as we're working through. So we talk with that. We talk about the presenting problem. Same thing that Dr. Boggs was just saying is follow-up questions. How long? Previous diagnoses, going through history of that presenting problem, and then previous psych history in general. When it comes to the personality disorders, that usually always kind of the hot button topic that everybody wants to talk about and how we go about it. I kind of have a personal rule. I don't know, I haven't seen anything out there as far as like it has to be this way, but I like to see people for at least 6-7 sessions and dig a little bit farther, because those personality disorders they can be pretty heavy, and there's still a lot of stigma that goes around them. I mean, even internally, it can be pretty harsh, right? This person has borderline, and everybody's mind goes fairly negative, right? So what that looks like, and really getting a good history of the client, and if they had, those that very, I'm blanking on the diagnosis, right, for the children. If they had similar symptoms to that beforehand, right, that lead up into that borderline. We talk a lot as far as training goes, the differential diagnosing and what that falls into and how that process goes. Because of where I used to work, I feel very medically driven and medical model driven. So starting off with the highest thing that we're going to come across, right? So if somebody comes in almost 8 times out of 10, they're going to come in with some form of anxiety. Then what comorbid with anxiety is depression. So that's just kind of that nice linear piece. So we need to be asking about depression. Once we go from there, we still need to screen And at that point, screening doesn't have to be the full assessment, but just seeing if they have them for bipolar, right? Unipolar versus bipolar, Dr. Boggs was talking about, and then doing the other screenings for psychosis, suicide, OCD, all the exact same things Dr. Boggs just said, right? So it's all fairly matches. Just
Can we just, because I'm watching Ian over there and he's going cross-eyed, can we can we clean up just a little bit of terminology like along the way, right? So one thing that keeps popping up is like personality disorders versus like other diagnosable conditions. Do one of you want to kind of tackle that in like just sort of a quick primer on what is meant when you say psychiatric disorder versus a personality disorder, or axis 1 versus axis 2? Do we want to, I don't think we have to go deep into the formation of the DSM and, get somebody test ready.
They got rid of the axes. Right. They flattened the axes. I mean, personality disorder, because it's really hard to say what's really personality,
Because I'm just thinking, like, if I'm going to get an assessment and I go in and
it's a history of, it's a historical diagnosis. Borderline actually used to be if they thought somebody wasn't psychotic or neurotic, somewhere in between. So this is on the borderline between psychotic and neurotic, whereas a neurotic would be just anxiety problems, and psychotic would be hearing voices, seeing things that aren't there. And then borderline was kind of on the border between the two of those things.
A little bit of both.
But so personality disorder, I think of it more as it's like a combat. See, everything has like a strong neurobiological correlate. So it's really not like, so to some degree, even that we call them personality disorders are really just like a historical vestige if they've been called that before. Because stuff like borderline personality disorder, that's one of the more common ones that we talk about, is highly heritable. So there's a lot of
learned or
stuff.
structural, like it's
probably both. Yeah. Probably both. It's like people that are on average much more sensitive than average and have a lot of adverse early life experiences, which can be horrific, frank trauma, or can be things that are small t trauma, but they're so sensitive that it impacted them like a big T trauma. And I agree with Casey. I don't rush to personality disorder diagnosis, not in the first couple of sessions, but it kind of, there's a natural flow to it if you can kind of start treating the anxiety, depression, that kind of stuff, and if like there's a lot of like interpersonal issues that are just absolutely not addressed through addressing the depression and anxiety issues, it can start to be something that kind of logically comes up as a possibility when someone asks the question, well, what the heck is wrong with me? Why am I this way? You can try to some degree help them figure out why they're that way, and then there's a learned component to the behavior with personality disorders, which means that the prospect of therapy and then kind of learning in therapy and then incorporating that to learn in your life is you can also unlearn, right. like you can change the way you process things, and so that's why like borderline's an interesting one where some people have it as a longitudinal syndrome, but most people that meet the full diagnostic criteria for borderline personality disorder at time A, most people don't within 2 to 5 years, like especially if they're in treatment. I mean, people can improve. And a lot of adolescents would kind of, if you take away the fact that they're adolescent, could meet the criteria for borderline or other personality disorders, but transiently as part of their adulting process.
It's funny because I worked with teenagers for a long time, and sort of one of the catchphrases that developed is that it's diagnosed as teenager, because, and I think that speaks to that idea of like, this is not a fixed person, and in 5 years, you're going to see a different presentation, even if nothing happens, right? Like we want healthy coping skills to develop. We want healthy supports, but teenagers by nature can be emotional and can have wildly fluctuating mood states and can have an inability to moderate those mood states and can lash out as a response and damage relationships. And these are all things that show up as diagnostic criteria, right? So something that shows up in a 35-year-old is not the same as something that shows up in a 15-year-old. And that's really important to keep that in mind. Is it fair to think about these types of disorders and problems as, when I say structural, I mean like literally my brain is functioning differently than somebody else's brain in terms of dopamine production, in terms of the actual reward systems of the brain, and then the other ones are more highly developmental in that they can change over time. They can be learned and unlearned. There's more of like a behavioral component where I can affect change, whereas I can do whatever behavioral things I want. If I have a structural issue, I'm probably going to be dealing with that disorder over a longer period of time. Is that fair, or is that too limited of an understanding?
Yeah, I think that's hard. I mean, we don't really know a whole lot. Like I think we pretend we do as a whole, right? Research is ever changing. I'm thinking, I mean, Dr. Boggs, you and I shared that meta-analysis that just came out, and there's so much that goes along with this. I started my career out in homelessness, and there's the statistic, 50% of everybody that's homeless has a severe mental illness, which includes depression. You're homeless, right? Like, I'm going to be stressed. I'm going to hate life. Like, I'm not going to want to go out and do things. Like, you're probably not sleeping, maybe not due to the chemical imbalances, but probably because you're around 40 other guys, with bunks. Which then leads to, lower motivation throughout the day, lower energy, which then, you know what I mean? So it just kind of keeps building on, but you take care of the homelessness and magically the depression kind of alleviates.
Right. Yeah, no, that's true. And there's probably a lot that might actually fall under the category of an adjustment disorder or an acute stress disorder or kind of a result of life circumstances. That's there too. So this has probably been really confusing if somebody's new to diagnosis. So what I think that, I think to start with, you're probably best off focusing on having a good conversation where you really get to know somebody. And be curious and inquisitive and ask a lot of questions. Make sure you hit some of the key safety things right off the bat. So a lot of things are okay if you miss them in session 1, but you can catch them on session 2 or session 3. You do want to ask if someone's going to kill themselves today, or someone else, So I said, and it actually can fit in fine with the screening with depression. Depression, you've been feeling sad. Oh, wow. Has it gotten to the point? Have you had thoughts that you'd be better off dead? No, yes, no. Well, have you thought about doing it? Are you having thoughts of how to kill yourself? And then have you done that, attempted to do that before? Have you been hospitalized before? And then that's like, there's a whole process that went into that. I feel like years for like where that felt like really intense and like hard to ask somebody. And then the more over time that you get in talking about these topics, that you can just be kind of conversational and almost not light in a disrespectful way. You're not like smiling while you ask someone about their suicidality, but it's also not, it is a symptom. These are symptoms that you're trying to find out about. And, so good conversation, follow-up questions, for sure, while you're getting started, if you want to have some kind of like tool, some kind of rubric to keep yourself somewhat organized as you're going through the process can be helpful. It's always great to ask kind of logical follow-up questions. So it's fine sometimes if you need to say, okay, break in conversation, let's talk about this. Okay, break in conversation, let's talk about this. But it's jarring for people, and it's not. So to the degree if, okay, well, they start talking about their depression and then they mention they've been drinking a little bit more. So then you can ask about their drinking and are there other drugs they're doing? And then maybe then that leads to their self-medicating. They have stretches of a week at a time when they don't sleep at all. And then it leads into questions about bipolar disorder. So you can have it flow so that you can actually get like a really good diagnostic interview without the person feeling like they were taken through a checkbox list.
I think it's important to start getting the work in early too. And Casey, you can talk about this probably because I know that you've had a lot of experience with this as well, but I like to pull that off of them as quick as possible. So instead of hey, have you thought about, not being here anymore? I'll say, so, a lot of times when people are dealing with what you're dealing with, or a lot of times in these situations, people can sometimes feel like they'd be better off to not be here. Have you been feeling any of that? So like you're normalizing and you're externalizing like right off the bat, right? So it implies that people have felt like this and they're still around, right? So we know this. And two, it's when they're going through this situation. So I'm already starting to plant that transitory nature of all of this. Like you don't have to be going through this all forever, right?
You're like a real therapist.
Hey, I sometimes,
wow,
right? Sometimes.
Look at that. Yeah.
But I think that's because it's your first session and that's your foundation. You're laying that foundation. I also think it's important to ask the counter. So what does it look like? Okay, do you have problem X, or have you dealt with this problem, anxiety, stress, sleep, whatever? When is that problem not around, right? And what are you doing then? Just so I get to know you. I just want to know what it's like when it's not there, right? And I think just the implication that there's times when it's not, because I think from a client standpoint, when people first sit down, and OKC with his CBT will jump all over this, it's a lot of always and never. Like I always feel, I never get to feel, the good stuff. And so I think it's like, I don't want, it is a bad analogy, but starting to get the wires out to disarm that bomb pretty quick are important, you know what I mean? And not let that run amok. So, I mean, Casey, do you do a lot of that yourself, or train a lot of that to that, like when the problem's not there, or working those techniques early? Or is it really about getting that good, solid diagnostic information on all of the blanks and then reassessing after the fact?
So the way I train is to get the blanks, and a part of that goes into credentialing, right, in our certifying bodies, because we have to have so much information that's basically it's laid out, and we have to get to that. So it's like this, it's an odd balance to try to have, where we want to gain all that information, not make it feel like a checkbox, still build rapport with clients while looking at the subject matter that we have to get completed. So it's I train on the side of completing it, then it's out of the way and building in. And so like when I start my intakes, I usually kind of brief them what we're about to go through, and I'll tell them, hey, I'm not trying to be, I'm not trying to be an ass, but I will have to cut you off at some points, so that we can keep moving through. It's all this red tape. I'm sorry, the man's doing it to us. It's just what it is, to try to keep that balance. But on those ones, those questioning, right, that trying to put those in a nice therapeutic or a subtle way versus just like, tell me about your trauma, right? Versus how you phrase even the suicide one, right? Lots of people have this when they're feeling depressed, or they come into places like this for the first time. Often they do have trauma behind them. Is there anything you've experienced that you would relate to as a traumatic event?
See, Casey's a real therapist too. See how you just wove that? I mean, that was nice. It was really good.
The nuance of it too, right, is like if you're not, it's like you have to get all the information, but you also need to communicate to them that you're nice, you're approachable, you're going to help them, you're going to work through this, because I don't know what it is. I'm sure we're much better at ANU, but there is a statistic that I heard once that quite a few people make it to one therapy session, and then that's it. So, so that's where like it can't. There has to be some more that they get out of it, to not only to what if it is their only session, but also to kind of help them realize that, hey, this is, so there's some education about the process too. Like it's not magic. You're not going to feel 100% tomorrow, but we're going to work together. We will get you feeling better. And I'll say stuff like that. Like you don't want to like promise a time, right? Because everything changes and is transient. So I believe in being honest. I would never, you're going to feel, 90% better in 1 week. But I do think I can, you can pretty confidently say, somebody's usually coming to you at kind of their worst. Sure. So it's usually very honest to say, we're going to work together until you're feeling a lot better. And that is, I don't think that's ever not been true, especially when people, because they're at their worst.
And you're certainly willing to keep working with them until, if it's a little bit, it's like the Indian rain dance. Like we'll just keep dancing until it rains. You know what I mean? Like, so I will hang in here with you. And I think that's nice. I think it's reasonable.
And then they know they're not alone. It's all this, and it brings up all these other positive expectancy things.
Yeah, that's good.
We try to talk a little bit about like tangibles, right? Because it's going to a psychiatrist, what do you get, right? You get your script, you get your meds, and that's a reason for me to continue to come back. And off of that therapy intake, you don't really feel better. You feel like you've just been poked and prodded. And so how do we close those, right? And that's a big piece of that is like the treatment planning and working that into it. Well, how do you want to get better? What are you hoping to get out of this? I can see us working together for a couple of weeks to teach you some coping skills, right? And so in session, I won't do a therapy because they are two separate services. You can get really deep, really quick on somebody on day one. But I'll give them, right? This is one of the most easiest ones. I'll do like a stop technique, which is stop, take a breath, observe, and then proceed. But just based off of maybe something that they've given me early on.
So like an early coping skill, I'm going to give you one thing to start working with between now and our next session. Try it out. If it doesn't work, fine. But at least you have the tangible, you leave with something. Yeah. I like to, if you get to a decent place with rapport, I like to also kind of predict a little bit of doom, because the irony of it is they're going to feel worse. If you start really considering your situation, you could get stressed out and you could feel that, right? And so I always like to plan a little bit of like, look, just saying that, it's literally like, look, you're probably going to, we'll get you feeling better. Ha ha ha. You're probably going to feel worse to start. Right, just so you know. And it kind of plants that seed where they can come back in and prove me wrong and go, I didn't. I felt better. You said I was going to feel worse. And it's like, oh, tell me more about that, right? Or if they do feel like crap in between, because the reality of like true like trauma processing is when you turn to kind of face that for the first time, it's scary and it's the thing you've been avoiding for so long, right? And so it's incredibly difficult. It's the new workout routine. It feels great to work out when you first start. It really sucks and you're going to hurt, And so to kind of predict a little bit of that and plant that almost like prescribing the symptoms, like, hey, when you start feeling worse, which you're going to, I need you to know that's not a permanent thing. Come back and tell me about it. And they'll tell me a lot about what we need to work on. Because then when they do feel worse, it's not, this isn't working, and you can get them past that one and done. It's like, I tried it. It didn't work. To hell with it. I'm out of here. It's like, no, that's part of the process. It's actually an indication you're on the right track, So
Dr. Boggs, I know for a fact, does that with his clients, right? I've talked to them as they're going through their meds, and they'll be 3 weeks out, and they'll just be, symptoms are coming from the meds, and they're just like, oh my goodness. But Dr. Boggs, he told me this was going to happen, so I got to push through it. And if I push through it, he said by week 5, I'm going to feel better.
No, I think it's smart to do some of that if you get to a place of decent rapport, because if they're still nervous and shook. And so this brings up an interesting question. So we're talking about templates versus like expertise and nuance. Your guys' opinion, who should be able to do diagnosis? Because in my head, when I think about it, if it's just getting the information, anybody can do it, right? But then when I think about our conversations around expertise and nuance, I think, wow, you really only want really well-trained, really strong clinicians doing it. So do you guys have any opinions on who should be allowed to diagnose or at least who should be allowed to assess? If they can't quite do the diagnosis, should they be allowed to conduct the assessment?
I don't know, but I think broadly speaking, I'm a fan of current laws. I'm a pro law abiding person.
Yeah.
Because it's also, there's also an ability to get somebody to actually tell you what's happening and to know how to ask about it and how to work with it, so that because we're also relying on people being open and honest and comfortable enough to tell us. Right. So that's where I think having a professional to help them work through it's essential. But there are really good, if somebody's gets to the point of kind of being open and honest and are willing to do something, there are like really long kind of more neuropsychological testing that they can do that answers hundreds of questions, and that can be useful too if they're willing to do it, if someone's willing to help them kind of process it and get through it. But
because and I want to hear from you, Casey, on that too, because I know you have some thoughts in that regard. But at some point, it's like, why not just a kiosk with a question and an algorithm that connects it to the DSM and says you've hit 6 out of 7. Take this paper to your local therapist and tell them what you got. You know what I mean? You can do, and as any doctor, I mean, I'm sure like, the WebMD thing, everybody can diagnose themselves with a brain tumor any moment now. You know what I mean? It's just like, I've got these 3 things. But if it's really just sort of connecting, because Case, you said earlier about like, okay, it kind of flows through the DSM, which is, the diagnostic manual that kind of outlines what these symptoms mean in terms of diagnosis. It's kind of like scoring, right? 5 of this and 4 of this get you that, So, I mean, I'm not advocating for that. I don't want the kiosk, but I mean, if you water it down too much, it's sort of like, where does it stop,
No, so I'm always kind of back and forth on this, because even the DSM-5 says, do not use this as a checklist. There is clinical judgment that has to go into these pieces. I think where I fall is maybe not necessarily like the assessment, but the information gathering could be somebody who's not licensed, right? Not necessarily going through symptomology, but there's so much, like in Ohio, there's so many nuanced pieces to those, to that intake paperwork. And it's very tedious. And if it's not relevant to the diagnosis, it can be, it absolutely can, right? You can always turn it, but a lot of the time it's like, who all lives in the home, who all is here, which are potential stressors, right? Looking at a holistic approach to the person and perspective that way.
And potential resources as well.
Yeah. But I could have that information already handed to me and I could look at it while asking about symptomology. And then making the hour about building rapport, just asking about that presenting problem, what you're here for, what you're hoping to get out of this. Oh, I see that mom and dad, or you live with them. How's that relationship? Is it going well? Great. So there's somebody we potentially can rely on, right? And so that's versus me asking, well, who all lives in the home? Great. Mom, dad, how's their relationship? What's their age, right? Like that's on this paperwork, which often gets placed into the diagnostic assessment.
Well, it sounds like what Casey said, even though he's focused on the diagnostic assessment, like there's a lot of helping that he's doing throughout the whole process.
It's a session.
So it is a session as well. So I don't know that you can get away from, and that's something you learn how to do over time and learn how to be over time. So it's much more than just a checklist. And also, I mean, it can be totally helpful in today's day and age to ask people, what do they, if they've done a lot of self-diagnosis, I'm happy to engage with that. Tell me about it and tell me why. I mean, sometimes people are spot on and other times it's just like they're way off, but they saw like a TikTok video and then they thought, because sometimes it's not so easy. This is where like, it's not so easy to answer some of these diagnostic questions. Like, what does this mean? Like if we go back to our borderline personality, what does it mean to have a pervasive fear of abandonment? What does that mean? Right. Like we're all like kind of afraid of being abandoned. Right. So you could say, well, I don't want anyone to abandon me. So I could say yes, but like, no. Is it like pervasive? Something are you thinking about it all the time? Is it like intense? Is it like, every day, multiple times a day, you're like terrified of how your partner's going to leave you. Even though on some level it's probably not logical, you're like wrapped up in it and you're stuck and it's causing you great suffering. Well, okay, so that's like a much more nuanced way to ask the question. And if you ask somebody with borderline personality disorder, they'll say, yes. That's right. That's exactly what it's like. As opposed to like if you just read the checklist yourself, you could be like, oh yeah, check, yeah, I've got that. So kind of figuring out what is a yes to the checkbox is not always so easy.
Well, and it also speaks to the idea of like getting diagnosed is not an outcome or a goal in and of itself, right? Like, so that's the kind of our next question. What does it mean? So in a medical model, if I go to my doctor and I leave with a diagnosis, that's a bad day most times, right? Like if I'm struggling with something and I leave with a diagnosis, it can be helpful because maybe that means now good treatment's on its way or relief is coming. But just for somebody who's sitting there like, I may be struggling with something, if you do sit with a therapist and leave with a diagnosis, what does that mean for somebody? Is that good news? Is that bad news? Like, what do you guys think about that?
I think like on my side, when I think about it, like I have a very particular client that just popped in my head. I worked with them for about 8 months before I realized the personality disorder was behind it. And it was when I came to, like I was just telling them, terminating the session or terminating the therapy essentially, because we weren't making progress. I couldn't figure it out. I sought supervision. We couldn't figure it out. And the pervasive fear of abandonment, right, is what came up.
So you terminated them?
Yeah, I started the conversation of terminating them. Yeah, and that's where that abandonment came in. What? You don't care about me? Oh my goodness, I'm just going to kill myself. I don't even know what I'm going to do without you. And so it was like, oh,
they just
there it is.
Unraveled in the session. Yeah, and you thought,
unraveled right there in session. We realized this is where we're at. We did the personality inventory next session, and then we started DBT the session after that, right? So they started to see better outcomes, but it was a piece of that. So having a good diagnosis can lead to better treatment.
And that's a great example too, where you see how there is a working component to the diagnosis. So to what degree is it relevant? Well, if there's good treatments for that diagnosis, then it's relevant. So so is it good? No, I mean, you don't want to, it's like any medical illness. You don't want to have a medical illness. I mean, but you're suffering. So if you can know why, and then you can get the right treatment so that you can feel better. So that's where I'd say I wouldn't, it's not like good or bad, but it's helpful. It's a helpful part of the process to getting you feeling better and getting back to your life. Because everybody is much more than the sum of their diagnoses or what, life is much more complex than that. But boy, if you're really struggling, it's good to know why. I mean, if you've got, if you keep coughing and it turns out it's some sort of pneumonia, then it's good to know what it is so you know which antibiotic to take or what other thing you need to do to get better. And I think I'd view diagnoses the same way too. And some people, and then it depends too. Some people find them very comforting and they find it very validating. And then for those people, you can lean in and it can be something you talk about. For other people, they're profoundly uncomfortable. So then you can just, you do the minimum you need to do in terms of talking about it with them. So there's informed consent. And then that's as much as you need to talk about it with them because that's not part of their journey to heal. You still need the diagnosis to explain what you're doing and why you're doing and to help guide the treatment. But for some people, it'll be an ongoing topic that they like to talk about and process. And for other people, it really won't be. Yeah. And that's okay.
I've seen the flip of that too, where there's a little bit of danger in the diagnosis sometimes where people sort of become the diagnosis. And then that's the label that sort of lets them off the hook for everything. It's no longer like I'm making bad choices. It's my bipolar acting up, or it's, because I'm borderline. And it's almost like a responsibility dodge, you know what I mean? Kind of a helplessness thing where it's like, oh, just, talk to the bipolar because I'm not really in charge anymore. I got this diagnosis. And we see that in addiction a lot too. When you get a dependency diagnosis in place, or, it's like, well, then am I helpless? Am I powerless? Am I completely dependent on that? It becomes a reason to not change. And I think that's pervasive too, in the sense that now, we worked really hard for many years, all of us in the field, on reducing the stigma. And I feel like in some ways we've sort of overshot that, where now these psychological and psychiatric terms are working themselves into just like normal daily language, right? And everybody has friends that are narcissistic or she's so borderline and toxic. And I don't know. I think that there's, I don't know. The watering down of the serious nature of what those diagnoses mean, I think comes with some risk. Have you seen any of that in your work or worry about that, especially with like younger clients?
Oh, yeah. Now, I mean, TikTok, Dr. Boggs just mentioned this, right? Having the TikTok piece. I mean, there's so much out there, like of self-diagnosing, self-treatment. Things are just really dangerous, I would say, especially like in the narcissist, like the personality realm. Even neurodivergent stuff is coming out, and so that's becoming the next hot button thing. Of everybody's ADHD and has a piece of this, and you're going to lose sight of, I think, the individuals who truly have it, and it's just going to kind of get pushed off as now you have individuals who are ADHD because of TikTok, and we'll call it on a spectrum, right? Light ADHD, but then the ones who are extreme, they're going to get labeled with something else, bipolar or something else, because it doesn't look like what the watered down version is.
Have you ever had somebody sit for an assessment and you just leave with nothing?
Yeah.
Like you don't have anything.
Well, like nothing at all?
Yeah, like you're good.
I haven't, but I've never had people like, only because like I'm a psychiatrist, it takes a while to get in to see me. There's a lot of filters. Like it's not like, it's not like like put up a shingle on the side of the, I mean, so yes, there probably would be some people that had nothing, especially if they did it as like an experiment, or they're like, let's try to punk the psychiatrist or punk the therapist. Like you could imagine that, and someone comes in, no, they got nothing. But most people, like at a minimum, if they're in enough psychological distress that they're seeking professional help from a therapist or a psychiatrist, I mean, usually at a minimum, there's an adjustment disorder. I mean, there's some, even if the diagnosis is adjustment disorder, they don't have a deeper underlying a neurobiological issue that requires medication, or they are struggling right now to such a degree that they're needing to come see a professional. So that then by definition is kind of like an adjustment disorder.
And I think that's important to point out too, is that it can be kind of evidence in both directions. If your life is disrupted in a significant enough way for a significant amount of time, there's things that need to be worked on, right? And if you want to call it this to get the work going, great. If you want to call it that, if you want to just say I'm struggling, that's okay too. You know what I mean? It's the disruption becomes evidence kind of after the fact that there's something that's a block or a challenge for you that you just might need some help meeting that challenge. So, because I go back and forth on it, the value of assessment, right? Because Casey, I want to pull back up something you said really early on where you were talking about the DSM, and you said, people think we know a lot, but we actually don't know a lot sometimes, right? Like there's 640 different diagnoses, and there used to be 10, and soon there's going to be 1,600. And it's sort of like, so, I struggle with that myself personally, which is like, is there really such great value to the assessment/diagnosis piece, or is it more important about establishing a relationship, getting the work going, and then alleviating that discomfort? Now, I see it both ways, right? Like obvious for some clients, it's individualized, like knowing that there's something up and that there's a plan for working on them, and then matching interventions to the diagnosis has great value, undoubtedly. But I also worry about that piece, Casey. Like, can you unpack that a little bit, where you said like it seems like we know a lot, but maybe we don't? Because I do think about a client sitting there hearing that word after their name, I have, and now it's like, ooh, that feels concrete, that feels specific, you know what I mean? So what did you mean by sometimes we don't know as much as it may seem that we know?
I think just because of the science behind it. I mean, it's still fairly young, right? Psychotherapy and psychiatry, it's new to the world, right? I mean, I would still put it as it's in an infancy. The brain is incredibly complex. There's pieces that we do know, but like I said, there's going to be research that comes out that says, oh, this actually isn't working anymore. As far as it relates to the diagnosis, I mean, we can sit and think that somebody is going to be on this realm, right? So they're a depressed individual, and we try all the different depressive medications, and maybe they elevate, but they just don't seem to be getting better. But if we miss somewhere along the lines, we through the assessment process, through the intake process, through the nursing assessment, the psychiatry assessment, we just missed it. But 1 year before that, the individual went to school and ended up getting kicked out of school because they went on a 4-day binger, and come find out it was this manic episode that landed them in jail. And they just assumed it was jail because it wasn't a psychiatric hospital, and they just, they were out drinking and it was no big deal. Like it was just a part of, the college experience, and they just moved on with it. That would label them under that bipolar piece. So we didn't know, right? Like we don't know these extra layers, and if clients don't see them as important, or if we don't see those, again, that sounds very major, but some of our clients, compared to the stuff that they're dealing with, it was nothing, right? Like it was just another night in jail. Like we moved on.
Because I often wonder about that when you talk about differential diagnosis, the fact that two clinicians could sit down with a client and assess them and come up with two different diagnoses. Now that happens in the medical world all the time. That's what second opinions are about, but I think it's important that people understand there is a level of subjective experience and subjective expertise that goes in. It's not just as simple as, 1 + 1 = 2 every single time, those secondary factors.
And like for myself, like I see things through a trauma lens, and that's just how I base my practice off of. And so I'm always looking, like that's part of my differential diagnosis, is when I get to that trauma section, is digging out those and piecing out irritability. When did that irritability start? Was it after depressive symptoms came, or did those depressive symptoms start coming after the trauma event? Because there are negative symptoms as a part of trauma which mimic depression. There are also the excitement that mimic mania. And so it's like this little bit of a puzzle game. But if you don't go through that, and I try to train the best I can, but that's like you said, there's experience that comes along with that you just have to kind of know and to kind of look and to see for it. Like for myself, I was lucky. I don't know if it was lucky or unlucky, but my upbringing as a therapist was with individuals with bipolar and schizophrenia. So I was on an ACT team when I first got my license. And so that's how I started my diagnostic journey. So it's these very heavy, severe clients, also dually diagnosed. So then pulling that out as well, right? With the substance use, was the chicken and the egg, which one came first?
Right. And it's so funny because schizophrenic's one of those terms that's worked its way into kind of pop psych and media where people like, they'll be confused and like, I'm just so schizophrenic today. And you sort of think like, that is a massive diagnosis. Do you understand what that would be like if you truly were? So a lot of it's just sort of like collections of symptoms that we get to talk about a certain way. For both of you guys on the psychiatric side and also just sort of on the therapy side, are there any either groups of diagnoses or specific diagnoses that you find to be particularly elusive, difficult to pin down, or are they all pretty straightforward for you in terms of like when I see a bipolar, I know a bipolar? Or are there others that can kind of like be difficult to really, differentiate from other disorders? Like, are there any ones that are particularly problematic in a diagnostic realm, or they all come with their own challenges?
I mean, there are their own challenges. There are different nuances to different things. Like bipolar is like you can look at a whole host of different symptoms that also overlap with a whole host of other things, but actually the diagnosis is made by, was there an episode of mania or hypomania in the absence of stimulant abuse? Yeah. And that's actually the diagnosis. Right. So, there's a lot of other like related symptoms, but it really comes down to that. But even that's kind of hard. If you look at the criteria for hypomania, like what do you mean by decreased sleep? What do you mean by increased energy? What do you mean by more talkative? What do you mean by increased libido? Like lots of people could say it's like, so, but it's still kind of getting at that. It's quite different from a normal state. Like we're not talking subtle here. We're talking major difference in the way you're thinking, feeling, and acting.
And what do you mean by no stimulant use, right? So my 16 cups of coffee, did that play a role, And
yeah. No. And it gets into new, yeah. No. Fair point.
And is that even true? Because like, in the addiction world, the shame and guilt, like hiding that a lot of times. And so you'll have people who swear up and down, nope, no stimulant use. You know what I mean? And it's sort of like,
well, they're on their 10th monster of the day.
That's exactly. Or the Monster energy drinks and that kind of stuff. So yeah. What about you, Casey, in the therapy realm? Is it also the same type of stuff, or?
I'd say, working more in like outpatient setting, like part of it, each one's going to absolutely have its own nuance, but one that I've been finding a little bit more is like the transition age youth, like 18 to 21, where you're going to see mania pop up, but if they had undiagnosed ADHD, right, and they just had this turmoil, right, distractibility, some grandiosity, flight of ideas, talkativeness, they start to mimic a little bit of each other. And if you can't capture that manic episode in a 4-day period, but it's like they have all these symptoms for the last 15 years of their life, right? You're kind of like, oh, I'm not quite sure which direction to go with this, just because lots of those symptoms really do start to overlap, kind of similar to that trauma experience.
Yeah, it can get confusing. And you can have multiple things too. So it's not that uncommon. Someone might have bipolar 2 disorder and ADHD and PTSD, all of which run in their family heavily and throw in substance abuse. And so so there can be multiple diagnoses, but it gives us the positive side of that. It gives us great treatments to use for different things to help people feel better. And for the new clinicians that have actually had the fortitude to sit with us through this entire conversation, I do think that so have your checklist with you. Absolutely. For years I did. So do it. Don't worry if you miss it in the beginning. Then you can look down at your notes and then ask it. So don't panic. Have your list. You can have your written list. And then the utility of it, as long as it's covered. Sometimes this gets weird in a hospital environment where they won't cover things that are unspecified. Unspecified is that whole spectrum of diagnoses are oftentimes where I will land on my first diagnostic assessment, where it's like, I've gotten to know the patient. I know they're struggling with some sort of mood disorder, some sort of depressive illness, unspecified depressive disorder, rule out. You could even rule out bipolar disorder, but that unspecified can be very useful. Like, I often won't delve into trauma at length with people until, usually it's far in the relationship with me because I'm not doing a lot of psychotherapy, but it's come up in the beginning that they had a lot of trauma. We haven't gone into the details. They have nightmares every night. And people in the past have diagnosed them with PTSD. Maybe a diagnosis I will often use for those folks before I get to know them better, before I get to see notes from the therapist, is unspecified trauma-related disorder. They clearly have issues related to trauma. It's clearly affecting them, but I don't know them well enough. I don't have a deep enough relationship with them. We didn't dig through, did they meet the full criteria for post-traumatic stress disorder today, or do I just know they had a lot of bad things happen to them and it's really affected them? And so then that's where the unspecified is a perfectly legitimate place to park your diagnosis. And then that can be your work on subsequent sessions, is to then piece apart the unspecified. So maybe for session 1, you've got an unspecified depressive disorder, an unspecified trauma-related disorder, and an alcohol use disorder. And so maybe that's what you have. And then it's part of the work over time in the coming sessions to tease into so they're not going to keep the unspecified depressive disorder for 5 years. It's like but it's a great, accurate placeholder.
Which I think, obviously we're never going to go this way. You can't put the genie back in the bottle, but I would have no problem if that's where it stayed. To be really honest, it clues the clinician into the fact that this is trauma related and these are their struggles, and everything else beyond that is going to be individualized. So I don't see much value in the increasingly narrow stratification of because of this, but not this, but also because of this and not because of this. And it happens on Wednesdays and Tuesdays after 4 p.m. Look, that's all going to come out in the therapeutic process. 640 different diagnoses. I think we need 20. Because the rest of it's the work. The rest of it's really the work, I think. And that's where I get on my soapbox a lot about art versus science, and let the experts be the experts. Let a Casey Montoya understand that you've got trauma-related stuff that's showing up in the following ways, and then let them work. And a lot of this is managed care worked in reverse, where we have to satisfy requirements and things like that. So it's a dangerous thing to say, because I don't want to water down the value of assessment. I think assessments, frankly, should probably never stop. You're assessing every session and on an ongoing kind of fashion, and it's fluid. But I don't know.
But I do think you're right, though. A lot of clinicians, we really are thinking about 10 or 20 things. And then there is some work to do the check boxes to kind of meet the other things. But there really is maybe 10 or 20 that we're actually making sure we cover, because it actually dictates what treatment are we going to do to get this person better. Whereas do we need to know, if we know it's roughly one of these 10 things, does it matter if it's number 489? As long as we know we're dealing with this spectrum, because and people are different, and people have such unique life experiences and different manifestations and combinations of things. We get at the complexity, how cool is the brain? 10 billion neurons on average, with thousands of different connections to other neurons. This is orders of magnitude more complicated than the most complicated computer. So it's awesome.
I feel like it's remnants of the medical model, right? Because this all came from medical model into testing, and in that world, it is important to know that you're operating on the correct elbow, or you're on the right part of the vascular system, or things like that. But I almost feel like it's a little bit naive, if not arrogant, to think it's ever anything but unspecified because you decided 10 billion neurons. How the hell do I know? Well, if it's these 17 versus these 20? And frankly, what's it going to change about my approach with them? It's still going to be a personal cure and a personal decision, and working with them as individuals to kind of find solutions for them, right? Regardless of their diagnosis. So, in case you're nodding a little bit, you feel kind of the same. You want 6, 10, 16 diagnoses? What do you think?
Yeah, well, I mean, I really kind of think about it the way that I do my treatment or my therapies is I do mine more symptomology based than I do the diagnostic.
That's all right.
Because you come in with sleep issues, okay, great. I mean, I know that's going to vary depending on anxiety, depression, but you can have somebody who's depressed who can't get to sleep because they have racing thoughts, but that's it, right? So they don't meet the criteria for diagnosis for anxiety, but they still have that issue. So I still want to treat that. So whether that goes to Dr. Boggs, right, for medicine to help them get through that. And then in my sessions, we talk about sleep hygiene and we work through that process. So hopefully they don't have to be on meds, to get to sleep, and they can do it a more natural way. But if you break it down to symptomology, I think we're kind of already there, right? Like the number of symptoms are probably, I would say 25, maybe 30, like combined symptoms between everything that we see, right? With some nuances out there.
Sure. 640 nuances. Yeah.
Yeah. So, but then compared to 600.
And then you see if there's treatments that cover, so if there's the 25 or 30, then you see if there's some treatments that cover, 5 of those or 10 of those, and then those become really good places to kind of start working.
Because beyond the 80%, there's not going to be much that changes within those subdivisions anyway in terms of approach. And I think it's important for people to know, because I mean, there's the therapist, the psychiatrist as the expert, and there certainly is some level of expertise that goes into that. But there are not 640 distinct approaches for those 640 diagnoses. And if you get one versus the other, it doesn't mean, oh gosh, you got number 645 intervention, not number 647. So now you're not going to get healthy. That's not what happens. The symptom reduction is going to happen all the time. And I kind of cringe when I hear that, Casey, because think about this, like how many people were denied care because they didn't meet the criteria, right? They needed relief. They were uncomfortable. But sorry, you check 5 boxes, not 8. And nobody would ever do this intentionally. I really want to go to bat for the ethics of the profession. But how many people have said, well, if I don't give you 8, you're not going to get care. So now I have to choose between, well, yeah, okay, and bye, go home. You know what I mean? That's tough. That's a tough spot to put somebody in. I
will back my therapist if they do that, right? Like if they don't have the criteria, because the DSM-5 clearly states in there, like it is not to be used as a checklist. It's clinical judgment is allowed, that you should use that. And it says something along the lines of, if you fall short of the criteria, you can still render the full diagnosis. So, I mean, I'll go against them. I'll fight.
Yeah. With their own book that they made up. So, all right. Well, we were never going to cover all of it, but we've covered most of it from our end. I guess before we close, I think one thing that maybe if we could drill down and really focus on is 2 questions. One, if you're somebody who's thinking about going to get an assessment, you feel like you've been struggling with some things, is there any help you can provide in terms of that? Now's the time, right? Like if you're feeling blank for a certain amount of time or whatever, when is it like, if I'm driving in my car, I'm going through my life and it's sort of like, yeah, I think things could be better, but I don't know if it rises to the level of like, I need to go get officially assessed. What advice would you give in terms of making that decision of when it's time to go and actually participate in a formal assessment?
I would say if you're thinking about it, it's probably at that point, right? Like you've recognized that something is not, moving in the appropriate way. Because if you're not, right, you're not thinking that something's bad, you're just kind of going through life and you're happy or you're content. I mean, sometimes life is just contentment, not always happy. Then yeah, but if you're driving in the car and you're like, man, my life, I got to do something about it. Like you're probably there at some point.
You agree? Sort of the same idea?
I would agree with and plus there's like a human choice thing. So go for it. If you want to get help, get help. For the person that's more like neurotic and it's like, out of the 36 people that watch this, if there's 2 that are just kind of worrywarts and Where
We're in the
you know,
mid 40s now.
mid 40s, where the viewership is picking up. Is it disrupting your life to some significant degree? Is it keeping you from deriving a reasonable amount of joy from your existence? And has it lasted more than a week or two? I mean, because anybody can have, bad things happen. It's understandable. Every day is not going to be amazing. So anybody, if you're thinking about it, go for it. If you want to, go for it. If you're actually trying to say, well, do I need help or not? Well, if yesterday you felt fantastic, and today you bumped your toe and are feeling a little down because your toe hurts, I mean, you might not need a psychiatric evaluation today. Maybe give it a few days and see how that toe feels.
And I think that's an important differentiation to people listening. Dr. Montoya is on the therapy side, right? Social work and therapy, and Dr. Boggs is on the psychiatric side. So, because when I think about it, it's sort of like, well, how out of shape do I need to be before I start going to the gym? That's therapy, right? Like everybody could benefit. Like you said, the human choice element. If you think things could be better, talk to somebody about that. Maybe you'll talk to them once. Maybe you'll talk to them for the next 10 years. But that's a support and that's an investment in self. I think the psychiatric piece is different, right? That's more, as I think about in terms of medical model, like, okay, is my leg broken? Like I need to do something here because this is more than just annoying. Like I'm having some functioning issues here that are continuing, right? And so I think that's important to point out. The last question that we'll talk about today with this is, okay, if somebody's made that choice, are there any tips or are there any advice? We always like to leave people with interventions or just kind of supportive techniques. If I'm preparing for an assessment or I've decided to get that assessment, like what can I do to prepare or what can I do to kind of get the most out of that? So whether it's how to behave during the assessment or things that I can do leading up to the assessment, what should I be prepared for and how can I kind of maximize that opportunity and get the most out of that?
I would say like whatever paperwork has to be completed up front, do it. Because that's kind of what I was alluding to before about like that having somebody complete the paperwork and then come in and do the assessment. If there's information that they're giving you that's like biopsychosocial stuff, like who's in your family, fill it out to the best of your knowledge. Because that's just more, I don't want to say more, that's less that the clinician at intake is going to have to ask you. Because they can just review it and go through and just check and double check those things and then really spend more time with you building rapport, building, potentially a more solid diagnosis around, whatever's happening with you versus having to ask all those questions.
I like that because I think it also helps them get to focused questioning faster, right? Versus just the exploratory kind of general probing. It can kind of hint to where we might be going. Dr. Boggs, what advice would you have for somebody to get the most out of their time with you?
I think, well, what I'll often tell people when they go to see any kind of doctor is make sure you write, you don't have to if you're somebody who can remember things in the spot, but these tend to be high affect moments. They're really charged. It's easy to forget things. So maybe write down a handful of things that are really important for you to address. So I'm worried about X, I'm worried about Y, this happened, make sure, so, if there are concerns that you really need to get addressed, make sure you write it down so that you can bring it up. And you don't have to do this, but if you're going in trying to be really helpful for a psychopharmacologist, if you can either take the time to remember what medications you've been on in the past, what's helped people in your family, what hasn't, what experiences have you had that have been really bad, what have you had that's been good, to the degree that you can, because I do end up in a lot of initial conversations where I ask and I say, well, I don't remember anything. I don't know what I've been on. And then I always have to ask, well, were you on X? Oh yeah, I was. That helped or didn't help. Were you on Y? And then, so, if you're trying to make the life of the psychiatrist easier, if you can do that kind of thinking beforehand and write it down if you need to, it's really helpful.
I'm imagining like what color was the medication and what was the shape and you're kind of like a PDR trying to identify it in real time. Yeah. So that's tough. I guess my contribution to my own question would just be to, I guess if you're going to take that step, really push yourself in terms of honesty. I think, I can assure anybody that's thinking about it, whatever you think you're going to tell your therapist or your psychiatrist that's going to blow their hair back or they're going to judge you, they have heard it times 100 in terms of degree and in terms of frequency. So really push yourself. I mean, I'm not a big rules guy all the time, but HIPAA's there for a reason. Confidentiality is there for a reason. Your information is truly safe at a state and federal level. So leave it all there, leave it all on the table. That's what we're there for. And really push yourself. That thing that you haven't told anybody, tell us. The thing that you're not sure whether it's important or not, let us know. We'll make that designation, and help you decide whether it's important or not. I think just in sports, it was all the leave it on the field. It's just leave it in that room. That's why those rooms exist, and really push and push it out there. So, all right. Well, we're close on time. I think that's it. I think we covered the history of assessment diagnosis, and there's nothing left to be discussed. I mean, that's all of it. But any parting thoughts before we go, KC or Dr. Boggs? You guys feel good about what we covered?
Yeah, I think so. It's a nice perspective for both, new therapists, even, seasoned therapists as well, hearing perspective from your guys, right? Having new perspective, because it's often, people get tired of hearing the same voice that's an instructor over and over again, or a manager.
And you can have notes when you start. You can have a cheat sheet. Don't feel like you'll remember it all over time, but there's no reason to put that pressure on yourself. When you're just starting out, absolutely have your questions you want to make sure you ask. It's fine. No one will think less of you as a therapist or a psychiatrist if you are thorough because you have a checklist and you go for it.
And move them around. Don't feel like the order doesn't matter. No. It's just move them around, because I think we've been put in that position where, like, in some forms, like literally, like the fourth question you're supposed to ask somebody is like of their most traumatic experience they've ever had.
No, I wouldn't do that.
You can ask about their hobbies first. You can ask about their strengths first. You can ask about their mom and their dad and their family history. And
start it with 5 minutes of chit chat. Start it soft. Unless they want to dive right in, you can start it with just who are you?
Right. Well, why are you here?
Where do you live? What do you do? What's been going on? How'd you end up here?
All right, well, we'll wrap it there. I do want to close up since we are talking about assessments. If you are in Ohio or you're in New Hampshire, Through Help and Back is fully sponsored by New Behavioral Health. So anewbh.com or help now at anewbh.com. The world changed with COVID in a lot of ways. You do not have to live down the street from one of the new offices. You can be anywhere within the realm of New Hampshire or Ohio, and you can get help through New Behavioral Health. One of the things I'm most proud of with the new is we're not competitive in the field of human services or territorial. If we're your answer, that's great. If not, it's not a bad phone call to make, because we can absolutely help you find the place that will be the answer for you. So you can check out the website. You can make contact there. Or like I said, you can always send an email and we'll reach out to you really quick. We're pretty fast. We've stayed fast and we get back with people right away. And that's a key factor, because with assessment, sometimes time matters, and you finally made that choice on Tuesday, and by Thursday you're over it and you talked yourself right back out of it. You're going to hear from a new between now and then and have an opportunity to get the help that you need, or at least get a proper assessment from Dr. Boggs or Dr. Montoya or one of our clinicians. So with that, I'll close. Thank you, Dr. Boggs, for being here. Thank you, Casey. Dr. Montoya, thanks for being here as well. Between now and next time, make sure and take care of yourself and take care of each other. Thanks so much.